Well, hello, everyone. I'm Jeffrey Saber, and it's my great pleasure to be with you via virtual technology to talk about some exciting emerging technologies in stroke management. Here are my disclosures. In the course of this brief talk, I'm going to cover 4 new technologies, 2 in the EMS setting, stroke detection by the public, and facilitating large vessel occlusion recognition by EMS personnel, and then 2 in the acute hospital setting, advances in endovascular thrombectomy and also collateral enhancement. Let's begin with stroke detection, which of course currently depends on the patient or witness recognizing stroke symptoms and calling 911. But unfortunately, that means that for the quarter to a fifth of patients who wake up with their stroke or have it unwitnessed and can't themselves report due to language or motor deficits, that the stroke isn't conveyed to the 911 system until well after it started. How can we improve that? We can take a lesson from the Las Vegas casinos, which probably have the shortest onset to door time for stroke in the country, because they have these cameras in the top of the casino continually monitored by security personnel who are instructed that the second someone stops playing, call 911, get the patient off the floor and to the hospital. And we are increasingly living in a world where this type of continuous monitoring is occurring automatically through voice, camera, smartphone, and a variety of sensor technologies. It's already been implemented for one mode of stroke detection and automatic EMS notification. The Apple Watch has a fall detection system, which often happens with stroke patients, and it will itself call 911 when a fall has occurred. We saw recently another patient who illustrates this emerging capability, a patient who woke to their Alexa alarm, tried to turn it off by speaking to it, but Alexa said, "I'm sorry, I don't understand what you're saying." And he realized he was dysarthric. He could text, but he couldn't get clear speech out. So this was a case we dubbed Alexia without agraphia. And in the future, the voice assistant could be set to also call 911 when it detects this type of aphasic speech, here due to this very small abnormality in Broca's area, baby Broca, causing cortical dysarthria. And we have an ever increasing number of form factors in consumer use of these devices that have increasing capabilities for biometric monitoring that I think will increasingly allow us to have automatic detection and alerting of stroke symptoms. Well, once you activate 911, we then want to be able to distinguish the patients who have large vessel occlusions in whom thrombectomy works best, who we want to try to bring to a comprehensive stroke center, from the patients with small and medium vessel occlusions in whom thrombolysis intravenous works best, who we want to bring to the nearest primary stroke center. And paramedics are pretty good at this with tools. They can get this right 2/3 of the time, but we do want to improve upon that. One way is to beam the neurologist into every standard ambulance to do a remote mobile video exam that's being developed. Another are the helmet technologies that paramedics and EMTs would clap onto the head of the patient when the patient had focal deficits, and they use a variety of physical modalities, ultrasound, EEG, infrared light, microwaves, and brain vibrations to determine whether the underlying stroke is likely large vessel or small vessel and ischemic or hemorrhagic. The newest kid on the block is the vibration technology, and it's coming out of California here from Wade Smith at UCSF, monitoring very micro fine vibrations that give a signature of LVO stroke versus other types of presenting neurologic deficits. Now let's turn to acute treatment, and we'll start with recanalization, the most potent therapy that we have for acute ischemic stroke, by reopening blocked arteries to resolve brain ischemia. And there was a very different evolution of this technology when it was developed for the heart to reopen blocked heart arteries. Over the first 30 years, it fairly quickly reached the point where, with angioplasty and stenting, cardiologists could open the arteries 90–95% of the time. The brain's a little more complicated, its cerebral circulation is more complicated, and so over the first 30 years with TPA and the early Mercy retriever, we were only getting the arteries open 20–30% of the time. Then we had a breakthrough in 2012 with the stent retrievers and aspiration catheters, and that allowed us to start opening arteries maybe 2/3 of the time. But since then, we've been iteratively improving with devices. Every 6 to 18 months, another device emerges, new retrievers, new aspiration catheters that have designs to advance the ability to pull clots out. Most recently, the EmboTrap device that pulls clots into the cage of the stent to allow them to be more easily retrieved. And the newest, just out last month, the Tiger Retriever device. And the Tiger Retriever device allows the interventionalist to control how much radially the stent opens. Other stent retrievers are self-expanding, but here the interventionalist can interact with the clot in this additional way and aimed to improve retrieval success. And the study was reported in Stroke last month of the lead-in and main phase of the Tiger trial. And it showed that patients treated with the Tiger Retriever had a higher reopening rate with that device than historically with other devices, 85% of the time opening with just the Tiger Retriever. And when you allowed rescue devices for the patients who did not open, a remarkable 96% of patients had successful reperfusion with this approach to therapy, starting with the Tiger Retriever, 96%. And this was associated with very good outcome, 58% of patients being functionally independent at 3 months. So we now, as of last month, have jumped to a 96% reperfusion rate. And the neurocath lab is like the cardiac cath lab. When we bring patients there with LVOs, we can be very confident we'll get the artery open almost all the time. The last topic I'll talk about is new developments in collateral enhancement, a form of therapy that is getting close to being used in, I think, US practice. Collateral enhancement is an approach in which, when you can't get the blocked artery open, you increase the blood flow through all of the connecting arteries that go around that blocked artery to get more blood flow to the target field using the collateral circulation. And an approach to improve collateral flow is to stimulate the Sphenopalatine Ganglion, the small cluster of nerve cells behind the maxillary sinus that provides parasympathetic input to the anterior circulation. And when stimulated, causes a substantial dilation of blood vessels, of arteries in the anterior circulation. Here it is in animal models. You can see the arteries open widely, and this results in reduced stroke size. And here it is in the pivotal trials in humans. This small toothpick-like device, electrode, is implanted within 5 minutes using a wand up the palatine fossa to be right next to the SPG. And then for 4 hours a day for the next 5 days, an external cheek stimulator activates the electrode and stimulates the SPG. The 2 impact trials testing this device enrolled a total of 1,253 patients who were not candidates for thrombolysis or thrombectomy, so the target artery could not reopen, 8 to 24 hours after onset of ischemic stroke. And in the subset of patients who had cortical ischemia, seen on CT, which are the part of the brain that has the richest collaterals, there was a striking improvement with 50% of treated patients having good outcome versus 38% of control patients, a highly statistically significant difference. Also seen was this dose relationship between the degree of stimulation and patient outcome, an inverted U-shaped curve. It's very hard for this to occur by play of chance, and strongly suggests that benefit is actually being conferred. This device is now already approved in Europe with CE mark as of a year ago, and is before FDA now for review, and may be approved sometime in the next 6 to 18 months and come into regular US practice. So those are some exciting technologies in the pipeline for acute stroke that I think have a good chance of helping us continue to break the glass ceiling and continue to have paradigm shifts that improve stroke care. Thank you very much for your attention.